Alright guys, we're going to start with our GU diseases. We're going to do cystitis, pyelonephritis, BPH, prostate cancer, and chronic renal failure. And so let's get started. Okay guys, so pyelonephritis is on page 1069 to 71. We're actually going to talk about acute and chronic pyelonephritis. There's a picture that's showing what a normal kidney looks like and one that suffers from the chronic version of pyelonephritis. So if someone has pyelonephritis, they have an inflammation of the functional units of the renal, or the nephrons. Acute is usually a bacterial process. So acute is usually a bacterial process, and the majority of those is E. coli. So the majority of acute bacterial, and what's responsible? E. coli. The problem with this is if we leave acute pyelonephritis untreated, this person could end up in urosepsis or in septic shock. So what usually happens with acute pyelonephritis? Well, what usually happens is that you have an infection that starts in the lower urinary tract system and ascends or travels up to the kidneys. Okay, so it ascends or travels up to the kidney. There are some risk factors that are outlined in your book. Some of those could be pregnancy, certainly reflux. What we call the vesicoureteral reflux is a condition in which urine moves back up from the bladder into the kidneys. This is a more prominent risk factor in kids, though. So certainly a urinary tract trauma, scarring, stones could all be culprits for acute. Now what happens with chronic is we have actual chronic inflammation, usually not bacterial in nature, and we get scarring. So scarring of the tubules, scarring of the tissues of the kidney. And it actually can be a cause of chronic renal failure. So acute pyelonephritis, so we have itis, which means inflammation. And so anytime we have inflammation, infection, we get certain types of systemic signs and symptoms. And so in this instance, systemic signs and symptoms could be the general malaise, the fatigue, the nausea, the vomiting, the fever, and the chills. And then you have your urinary tract types of signs and symptoms, such as the frequency, the dysuria, the pyuria, hematuria, the flank pain, the costovertebral tenderness. That's what the tender CVA stands for. People with chronic can develop hypertension and an inability to conserve sodium. Okay, we suspect someone has pyelonephritis, then we need to do a UA. Okay, so we're going to look at the urinalysis. Is there the presence, for instance, of pyuria? Is there bacteria in the urine? Are there blood cells in the urine? What is the bacterial count? Is there nitrates in the in the urine? And it's possible that if the culture is positive, we need to figure out, is it gram positive, gram negative? And if the urine culture is positive, then we know we need a sensitivity. The sensitivity, remember, is necessary because we need to know what antibiotic is effective. And just remember, essentially, cultures usually take like 24 to 72 hours. So we often will do the urinalysis, but go ahead and treat with antibiotics based upon the fact that we know the majority of the times pyelonephritis is E. coli. We'll certainly look at a CBC, look at a differential. This person's probably going to suffer from leukocytosis, which remember means an elevated white blood cell count, possible increase in neutrophils. We can look at an IVP. We already talked about an intravenous pyelogram. Is there any structural or functional abnormalities of this patient? A KUB looks at the same thing. If we need to, you could do a cystoscopy. A cystoscopy could tell us for, like with the guy, is the reason we have pyelonephritis an enlarged prostate? Are there any strictures? Are there any bladder stones, tumors, etc.? When we're looking at chronic, we're usually basing that upon a history and the fact that they've had repeated episodes over a longer period of time. Okay, so once diagnosed with pyelonephritis, what we want to do is manage it, and obviously we want to assess why does this individual have pyelonephritis and treat it. So often the first thing we do, excuse me guys, is we start them on antibiotics. We've done this after we have obtained our urine culture. If you look on page 1070 in your med-surg text, it kind of shows you how we would treat someone if they had mild symptoms versus severe symptoms. If the issue is reflux, as we talked about previously, then there could be possible surgical intervention to correct the anatomical issues. If someone is dehydrated because they've had a high fever or been unable to tolerate fluids, then they might possibly need fluid replacement therapy. If someone developed pyelonephritis because they had a kidney stone, then we would look at their kidney stones, what are they consistent of, and possibly change their diet based upon this. So often the first thing we do is antibiotics. And because this is an issue with the kidneys, it's generally a longer term therapy of antibiotics, 10 to 14 days. Uncomplicated often are treated with what we would consider sulfa drugs. And so, let me see here. These right here are your sulfa drugs. Okay? Now remember, we said the majority of pyelonephritis is E. coli, so a lot of times sulfa drugs, so they're inexpensive, they're cheap, you only have to take them a couple of times a day, they're not necessarily effective. Remember, when someone has been placed on a sulfa drug, that we need to check for sensitivity to the sulfa drug. We need to make sure that they always take all of their antibiotics. And sulfa drugs also make you sensitive to the sun, so we need to talk to them about sunscreen. Now, the next group of drugs often that we give is where macrodantin falls in. And the problem with the macrodantin is, yes, it's an antibiotic. It covers both gram-negative and gram-positive bugs, but it often has to be given 3 to 4 times a day. And someone who is on it for a long term could actually develop pulmonary fibrosis or neuropathies. Okay. Other antibiotics that we might give are what we call the fluoroquinolones, and these examples would include your ciprofloxacin, which is Cipro, which we're very familiar with, the levofloxacin, which is Levaquin, which we're familiar with also. They're often saved to treat more complicated pyelonephritis or UTIs, and like I said, an example is Cipro. Also, urinary analgesics, these are not antibiotics. One of those is considered pyridium. Pyridium is used when someone is having bladder spasms. So it is not an antibiotic, but is often used in conjunction with. Helps provide a soothing effect on the mucosa. What we need to know, or what we need to tell our patients, is that it can stain the urine or change the color of the urine to like a reddish or orange color. Could concern clients. They think that possibly they have bloody urine, can stain underclothing, and it can also actually stain sweat and tears, so it could stain contacts. Let me see if I can bring in a photo here of Cipro. Yeah, let's bring this in. Okay, this is a photo of Cipro. Kind of tells you about Cipro, some of the things that we need to be concerned with, and you guys need to know that we need to make sure that they take all medicines as directed, lots of fluids, don't take with antacids, sunscreen is protective clothing, monitor CBC, liver and renal studies, and blood glucose, watch for super infections. Alright, so if someone keeps having reinfections, then they're typically going to be placed on prophylactic antibiotics. And if someone's having a lot of pain or fever, we give them NSAIDs such as ibuprofen or acetaminophen, which is Tylenol. Okay, some of the nursing diagnoses that you could possibly choose for someone with pyelonephritis. Alright, so first of all, this person has an infection. So actual infection. What do you need to do? You need to look at their history and physical and look at the signs and symptoms that suggest that they have an infection. Check the UA. Look at the culture and sensitivity. Is the patient on the right antibiotic? Look at the imaging studies. What did they show? What's the CBC? What's the white count? The differential? Is it elevated? Are there blood cultures that had to be drawn because the patient's possibly septic? You need to then implement temperature management if the patient has a fever, making sure that the patient's not only getting some type of analgesic for their temperature, but also receiving adequate fluids. And then if they have an infection, then we need to make sure that the patient understands why they're taking the medicine that they're taking, the fact that they need to take all the medication that they're taking, and that they need to get a follow-up urine analysis after the antibiotics are completed. This is typically done 10 to 14 days post completion of antibiotics. Okay, let's look at knowledge deficit. So, one, does this patient understand how to give you a midstream clean catch urine? What do they understand about pyelonephritis and why they got it and what they could do to prevent it in the future? What's the treatment plan? Why should they take all of their antibiotics? Help them to understand how to take their medicines, when they should take their medicines, with or without food, that they need to keep all their appointments, and that they need to come for a scheduled urine culture, and how to prevent in the future. As far as activity intolerance, really just let them know that rest will help decrease the discomfort that they might have. Then going down to the one where we have impaired urinary elimination. So we need to monitor intake and output. We need to monitor what the urine looks like. What's the color, the clarity, the odor. We should see an improvement in this after 48 hours on antibiotics. Okay? We need to instruct them typically to avoid certain drinks, caffeine, coffees, teas, citrus. We need to teach them, or we need to, if they would happen to have a Foley device, strict aseptic technique, and how to clean this system. We need to watch the eyes and nose and make sure that we don't need to do a straight cath. And that we need to provide regular Foley care if they do have a Foley. I'm going to talk a little bit about cystitis, inflammation of the bladder. We know that this is much more common in women than men. We also know that typically we don't know why people have it, that it's not usually caused by an infection or a chemical irritation, and that the cause remains unknown and a lot of times is associated with different factors in your clients, and they have to be able to keep a diary of things that cause or set off the cystitis and hopefully avoid those in the future. There's an irritation with the bladder lining, as we saw in the previous slide, where there are actual pinpoint hemorrhages that occur. This irritation also shows up in the urine, and the different causes could be a sympathetic nervous system dysfunction or possibly a reflex sympathetic dystrophy function. Some of the signs and symptoms that are associated with cystitis include this frequency and urgency of urination. There's pain, often like of the mucosa of the bladder, but the pain is relieved by urination, but then comes back once the bladder starts to fill again. They have what we call a small bladder capacity, meaning that they are not able to hold a tremendous amount of urine. And two, as I was saying, different things set off episodes of the cystitis, but it can be related to food or activity. To diagnose cystitis, we need to get a urinalysis. It needs to be a clean catch or cath. We need to look, what's in the urinalysis. Are there white blood cells? Are there nitrates? Do we need to do a culture and sensitivity? Let's look at the CBC, what's the white count doing? A lot of times a cystoscopy where we go up and we're actually able to visualize the liner of the bladder to see if there's any pinpoint hemorrhages. The picture that you first saw, that's what was going on. We were looking at the bladder and what you saw were pinpoint hemorrhages. A lot of times they'll do a voiding cystogram. A voiding cystogram actually helps to identify a bladder that has a small capacity. In other words, what amount of urine is the patient actually able to hold. And we always can look at the structure of the units of the bladder and do an IVP. This is just showing a couple of the different tests that might be done to diagnose cystitis, which is a cystoscopy. This is actually a rigid scope, and then a IVP, which is an intravenous pyelogram. Some of the treatments that can be used to help manage cystitis include certain over-the-counter agents that are considered alkaline agents, or agents that help make the urine alkaline. One that your book talks about is called Pre-Leaf. Another one is urinary elimination management, getting yourself into a routine urinary elimination pattern. Another one is diet therapy. We said certain types of foods are considered bladder irritants. Some of these include caffeine and alcohol, citrus, cheese, nuts. These are listed on your book on page 1072. So patients need to keep a diary and avoid the agents that cause an exacerbation of their cystitis. Stress can also cause an exacerbation or flare-up of cystitis, and so we often encourage patients to avoid stress and use relaxation therapy. Certain tricyclic antidepressants help reduce the burning pain and urinary frequency. These include the most common, amitriptyline and triptyline. And then there is a surgical procedure, and it involves a cystoscopy. And so these patients have a cysto or a cystoscopy. They have a medication instilled into the catheter. The urinary catheter is left in place, and the dimethyl sulfide is then left in the patient's bladder, and it is supposed to help deal with the pain receptors. And so the patient has this medication left in their bladder for a certain amount of time. All areas or surfaces of the bladder are exposed to this medication, and then the bladder is drained. And this is supposed to help desensitize the pain receptors in the bladder. These are the nursing diagnoses that go along with cystitis. So for instance, with the acute pain, these patients would need to realize the source of the pain, possible take antispasmodics, pain medications, try to avoid the triggers that cause an exacerbation of the cystitis. Knowledge deficit is the same. This is a learning process. The patient has to realize that they're going to have to identify what causes the exacerbations of their cystitis and try to avoid these situations in the future. I believe that we have pretty much covered all these as far as the meds, the urinary output assessment, dietary management, and stress management. These individuals just have to maintain good nutrition. They have to be able to identify their dietary restrictions that are often necessary. A lot of times this also means they have to watch what multivitamins they take. They need to document, what is triggers, and they need to keep a log about, how often they're going, what their symptoms are like, maybe over a 3-day period, determine the amount of frequency, the patterns, is there nocturia, what's the pain, and be able to share this with their physician.